recording. There we go. And we have the a link to the recording, and the slides are always on our CRIB webpage. So good afternoon, everyone. I'm Vanessa Cresci. I'm the director for the Research and Public Health Department, and we're always happy to host this call every twice a month. And you may have noticed recently kind of like a flurry of changes. The series ended, so I had to renew it. In addition to that, I'm trying to be consistent in one ID. So you know how if you're familiar with making changes in Zoom, it can create challenges if you have a large distribution group list. So please bear with me with those challenges if you see multiple emails from me. And if you could, please also sign in the chat so we can include that in our notes as well. We do get asked for copies of the notes and documentation that people attend. So it'll be great if you can add your name and sign in. So in case you are one of those individuals that ask us, then we can provide you with that documentation. So we'll go ahead and get started. So this is a snapshot of new confirmed cases in California by date. And so we are definitely, like as I mentioned the last call, we're in our second wave and have more than doubled our cases since the first wave. So our highest to date has been 35,729 cases. And then the number of deaths, we also reached a high of 225. So this is statewide. And we also include this information in our situational report. And I do want to share that according to the California threat level, we are in a severe outbreak. So our positivity test rate is about 10%. So we are definitely in a serious situation right now. And for positive cases by IHS area, so for California, clinics have reported 3,091 positive cases in a total of over 43 tests being conducted in California for the California area. And then we also show for data from the California Department of Public Health. They show that there's over 3,400 positive cases among American Indian, Alaska Native in California. That was as of yesterday. And then using data that we obtained from CDC, which also is a different number, they're showing a total of over 5,000 cases. So 5,335 positive cases among American Indians and Alaska Natives in California. And this is an updated map using the Indian Health Service data, and we created a regional map. So we have seen from the last map that we reported out at a last meeting, there's definitely been an increase of positive cases and also overall testing. So a majority of the positive cases are in the North Coast, what we're calling North Coast Cascades area. And these are both tribal and urban clinics. So it's using the IHS data. And for those who did not notice, because it was kind of buried, may have been buried in your emails, but there was a Q&A session today, and we were just notified earlier today, so it also got buried in my emails. But you can go to the link here and still view the video. It's been recorded, so you're more than welcome to still click on this link here, and this is what the video looks like. But it's, and I haven't watched it either because I was on another call. So I'll have to listen in later on, but it is available if you're interested in hearing the conversation between Dr. Wilson and Dr. Fauci. And then we, as always, we have our CDCF Foundation staff available to assist tribes, tribal health programs, and urban Indian clinics. So please feel free to reach out to us for any TA needs that you may have. And this was a screenshot of I guess a release that was disseminated out by the Indian Health Service. So the left was already been shared at our last call, so you can see how many clinics are going to tribal health programs and urban clinics, and for the California area, said that they would work with the Indian Health Service. And then on the right is the anticipated doses. So you may have seen a letter come from our area office director that California area is anticipated to receive 975 doses of Pfizer vaccine, and then 5,100 doses of the Moderna vaccine once it has obtained FDA approval. So this is just a snapshot. The Indian Health Service, if you've been following their Facebook, they are posting pictures of tribal communities that have actually received the vaccine, and then picture of the first IHS employee who received the vaccine that was out in Navajo. So they have shared pictures of the vaccine being distributed in tribal communities. I think they showed Cherokee, Navajo, and there was another one that they shared. So they are out in tribal communities now. And as mentioned in the last call, CRIB does participate in CDPH's Community Vaccine Advisory Committee, and that is Dr. Thomas Kim, so he participates on CRIB's behalf. And here is a link to learn more information about the committee and their roles and responsibilities. And also their meetings are public. So they do have a live stream on YouTube, and there's a telephone call line too if you're interested in joining that committee meeting. Also from the state, they have put out information about their Cal Notify program. So you can add it to your phone, and it is the exposure notifications. So I've added it to my iPhone, but this is another way to get notifications, exposure notifications on your phone. So there is a link here to find out more information about this and ways that you can share this information with your communities. And here is this our lovely slide of who you can contact for further information. And then we still are putting out our public service announcement videos. So we've recently released the Central California Southern videos. So that was representing Tejon Indian Tribe. They had someone from Tule River also there, and Santa Rosa Rancheria. So those videos were sent out via social media. In addition, we are still in the process of completing the Northern Central California videos and the Sonoma-Mendocino County area videos too. And here's a link to all of the videos, and please share and disseminate as well. So next we have Dr. Kim, who's going to give a brief update about vaccine. I know that's on top of everyone's mind, and it has been flooding the news waves too, and the news channels. So Dr. Kim, he's here somewhere. There you are.
I am here. Hi, everyone. Let me go ahead and
stop
get
sharing.
My slides up. Great. Okay. All right. Sorry about that. That's not super ideal, but okay. So again, I'm Thomas Kim. I'm the medical director at CRIB, and I wanted to give just a quick high-level view of the vaccine that is now being distributed as we speak in California and nationally. And so that's the Pfizer-BioNTech vaccine. There's a lot of information coming out right now. I am just barely, I feel like, getting on top of the material that's coming out, and there's going to be more to come. So in between all our work over at the epicenter with case and contact work for clusters, I mean, we're trying to also stay up on the latest information here as well. So for this vaccine, and the first and most important thing to remember is that we critically need vaccines to control this pandemic. There is no way, given the way this virus transmits, um, through asymptomatic and pre-symptomatic transmission and how contagious it is, that we're going to control this pandemic, uh, through the means that we have currently. So this is a huge relief, as you know, globally, that these vaccines are coming online. So the Pfizer vaccine, as it's known, was actually started. They started developing this on January 10th, and so from January to now, that's an incredibly fast pace. Most vaccines, as you know, take years, if not decades. The emergency use authorization by the FDA was just last Thursday on December 11th. And then the following day, the CDC Advisory Committee on Immunization Practices, or ACIP, met and made their recommendations. And soon after, 2 days later, we started getting shipments here to California. So very rapid, extremely rapid, but it matches the need that's out there. Now, this is a new type of vaccine. This type of technology has not ever been used before. It is a strand of genetic material called messenger RNA. It's a small, short strand of genetic code, and it's in kind of like a fat bubble, a lipid nanoparticle. It's in this like bubble of kind of like makes I guess fat, and because of that, it's not as stable, and that's why these vaccines have to be kept in ultra cold storage. Now, this genetic material encodes for a specific type of protein. It's called a spike protein. So, as you know, like those pictures of the SARS-CoV-2 virus, there are these like big protrusions, and those protrusions allow the virus to enter into cells. And this vaccine, actually, what it does is it sort of gets enveloped and then pulled into our own cells. And the genetic code actually gets into our cellular machinery, as it were, to create protein. So cells read genetic code to create a protein. And this vaccine, what it does is it slips that genetic code of the virus, the S protein, into our cells. Our cells don't know any better. They start reading that genetic code and they create this S protein. And that S protein then, it can get exported out of the cell, or if that cell dies, then it spills out all these S proteins into our body, and our immune system responds to it, and that's how this vaccine works. It's a injection into our muscle, intramuscular injection, and it's the way it's provided. And Carolyn can speak more to this. There's an ultra cold storage chain. It needs to be stored in that -80 to -60 degrees Celsius, and then when it's used, it can be refrigerated in a standard vaccine refrigerator for about 5 days. But when used, it's got to be diluted. So there's a lot of steps involved in using this vaccine. Now, the way that this vaccine was looked at for safety and efficacy, and I'm going to focus on what's called the phase 2 and 3 trial. Now, this was a relatively large trial. It was multinational. So it included the US, Argentina, I think Brazil, and South Africa. And these were stacked phases, meaning that they ran 2 overlapping with 3. And usually these are just done sequentially. And that's why vaccine trials take years, but what they did is they ran multiple phases at the same time to say, to get this out earlier. It's placebo controlled, so you've got the study vaccine compared against a placebo, and we'll talk about that more a little bit later. It's observer blind, meaning that when it's given to the patient, they don't know whether they're getting the vaccine or they're getting the placebo. And it's not also known to the provider who's giving the vaccine or placebo. They don't know if it's either one as well. Randomized is very important. A randomized trial is very important because there's so many different factors that can affect, say, a trial like this. For example, someone's immune status. Everyone's immune system is different. Some are stronger than others. And so by randomizing them to either getting the vaccine or getting the placebo, if they're people of, like, say, low, their immune system isn't so good, at least they'll be, the hope is there'll be an equal amount in each group, the study arm and the placebo arm. And there's like thousands of variables that we don't even know of, but the hope is that it'll be equal on both sides. So it'll sort of cancel out. Their effect will be canceled out. And this trial was for a minimum of 2 months follow-up, okay, looking at safety and efficacy. The participants, they're 12 years and older, but mostly 16 and older. I think there's only like about 100 kids between 12 and 16. So it's primarily, late teens and older. You just had to be healthy, or if you had a chronic medical condition, it just had to be stable. I believe that they even included people with HIV, but it was totally under control, and they were included in the study. The randomization is 1-to-1, meaning for one person placed in the study group, one person was placed in the placebo group. And so for those in the vaccine or test group, there was 18,556 people. In the placebo group, which they got a saline solution, just salt water, that was 18,530. So just essentially half. And they received 2 doses, 21 days apart. These are some of the characteristics of, they're different sort of, it gets a little confusing, but they're different like groups, subgroups. And, but this is the efficacy and the safety groups are roughly about the same size. So I just chose the demographic characteristics of the safety population. So this is pretty representative in the entire study, pretty close. So what you'll see here is that this column are for those who were in the vaccine group, and this column are those, the number of people in the placebo group. And what you'll see, there's pretty good male to female balance. As you can see, for race and ethnic groups, there's a real predominance of white race, a little over 80%. And of course, of great interest to us is the Native American, Alaskan Native population. And it's it was 102 that, and these are by self-report in the study group, and 99 in the placebo group, representing both of them 0.5% in each arm, or a total of 201 people, or 0.5% of all the study participants. So that's actually half of the, probably a little bit less than half than the national percentage of Native Americans. Again, it was broken down, or several countries participated, but it was largely in the US. And the age group that was predominantly studied, a large majority of them were 16 to, or actually a little over half were 16 to 55, and about 40% were older than 55. So that's the basic breakdown of, oh, and let me just add to, about a little over 1/4 were Hispanic or Latinx, which is important as well. So that's the basic demographic background breakdown. It's the key point here is you'll have fewer than the sort of overall percentage of the U.S. population of Native Americans represented at 0.5%. Now, when it comes to looking at efficacy or how effective these vaccines are, you have to define kind of like what you're looking for. And so for this study, the primary efficacy endpoint is looking for PCR confirmed COVID-19 infection with symptoms, and they define a certain list of symptoms. But it only counts if it's 7 days after the second dose. And it has to be in participants there's no evidence of prior infection. So that cut it down to a total of about 36,500 patients, or participants, I should say. And what they found, well, first of all, their goal was to, their threshold for efficacy was 50 to 60% efficacy. And so what they started doing is counting the number of cases over the 2 months in both arms, the vaccine group and the placebo group. And what they found, there was 8 people that developed COVID-19 and 162 who got infected in the placebo group. So that's a real big difference, 8 to 162. And this is in the midst of, over 35,000 patients. Now, this is calculated to be what's called a vaccine efficacy of 95%, which is really high when you think about the influenza vaccine, which is generally considered to be around like 40 to 60%, depending upon the year. So this is actually it was kind of surprising, this differential, 8 and 162. And you could also see that that split between the vaccine placebo group started relatively early, around by day 10 to 12. I'm not going to go too deep into this graph here, but this is on the y-axis is the incidence, cumulative incidence. These are like new cases, and this is the x-axis is time in days after, and they're looking at dose 1. The blue line here are the increasing number of cases in the placebo arm, whereas in the red line here are the number of, the cumulative incidence. This is the percentage of new cases in the study arm, the vaccine arm. And is that, as you can see, around day 10 or so, these are days, you'll start to see a divergence. They track together and then they split. And so you can clearly see that the vaccine did have a protective effect. This group did not add new COVID infections over time, starting around day 10 or 12. Okay, so that's, once graphically presented, it's pretty dramatic. They also looked at efficacy overall and by subgroup. And overall, what's of note, actually the main point I just want to show is that they did not do a subgroup analysis for Native Americans. And so you just gotta keep that in mind. It doesn't necessarily mean that that is an issue, but it just means that there is, a somewhat of a gap in our understanding. But overall, the sense is that there is not too much difference in efficacy by race, from the data that has been collected thus far. In looking at safety and the percentages that I have, they're going to be 2 percentages compared to each other. The first one will be the vaccine study group, and the second will be the placebo group. There were several different endpoints, safety endpoints. They were looking at local reactions or local reactogenicity, and they're looking at systemic reactions. And this is more global, like fever or, muscle ache or fatigue. The local reactions are where you get the injection and kind of the pain or the swelling you have there. And they also wanted to see if people, for any reason, used an antipyretic, meaning it's like a Tylenol or ibuprofen to stop a fever, or use a pain medication within 7 days of the injection. And what they found is in the 15 to 55 age range, this is after the first dose, they found for local reactions, the main local reaction is pain at injection site. So clearly the vaccine, 83% of the people had a local reaction versus 14 in the placebo. And then for systemic reactions, the two top systemic reactions were fatigue and headache. And you had more 47% versus 33% for fatigue in the vaccine group versus placebo, and something very similar for headache as well. When you looked at the age group that was greater than 55, for local reactions, these folks had 71% had in the vaccine group had pain at the injection site, and 9% in the placebo group. And then a little bit lower percentages for systemic reactions. Fatigue was 34% versus 23, headache 25 versus 18%. So just kind of like a global picture, side effects were less common somewhat in the older vaccine recipients. And overall, most of the side effects were mild to moderate in severity. What they did notice, though, was after the second dose, there tended to be more systemic reactions tended to be worse after the second dose. And that kind of makes sense because the body has already been primed to respond after the first dose. There were 0.6 versus 0.5%, vaccine to placebo, serious side effects, so not too different. And that doesn't mean it's related to the vaccine because it included people who just normally died if they had like a heart attack or what have you. And this is a rate that's not different from the vaccines we typically use. This is a busy slide. I just want to say too is that on the left, right over here, is the local reactions, and by far, pain at the injection site was an issue. And you can see the difference. The left would be the study group, and on the right is the placebo group. On the right is the systemic type reactions, and the two biggest ones are fatigue and headache. So basically, these different lines are dividing it by age and dose 1, dose 2. So in any case, the other types of reactions that they saw were locally some redness and swelling, and systemically they saw some fever, although it was not as high as you would think. It's less than around 15% or less. But then some people also got chills, nausea, vomiting, diarrhea. There are like some people got muscle pain, joint pain. So those are things to just know that they are known side effects of the vaccine itself. Now, obviously, adverse event surveillance are looking for not only just side effects, but really negative sort of effects of a vaccine is important, and it's ongoing. There is a system called the Vaccine Adverse Event Reporting System, or VAERS. It's been around for decades, run by CDC and providers, but also individuals like you can, if you're not a provider, can report through the system. This is really important because there are some really rare side effects and adverse reactions that, for example, like this study only had like about 40,000 people, but there are some really rare adverse events that maybe occur 1 out of every 100,000. And so you'll never pick those up, or you typically won't pick those up in these trials. But once it's given out into the general public, then you'll start seeing them. And we need a system to pick that up, and so that's VAERS. And also there's sometimes adverse events that are delayed. And so, this study, this trial was only about 2 months long. But what happens if there is an adverse effect that may take 6 months to develop or longer? So that's what the system's for. There's also another surveillance system called vSafe. And this is what's called active surveillance. You have to enroll in this. Perhaps I can do another talk on this later, but basically you can enroll your patients into this, and it's a way of reporting. You'll be triggered to report on any symptoms and any issues, and then I'm not sure if it's I think it's by an app or through texting, you'll be able to reply. And so they'll collect information that way. So more people that can get enrolled in this, the better. There are several different items that need to be reported listed here. I'm not going to go through those. But also just want to say too that Pfizer is continuing with more studies, especially looking at subgroups. We're very interested in pregnant women, healthcare workers, immunocompromised individuals, and so that will be ongoing as well. Just a side note, I know that Rosario sent out an email this morning regarding that, this is just an example of one of many informational webinars. This one is by Pfizer directly, and this sounds like it's more technical and for clinicians and healthcare staff. So just in summary, the vaccine efficacy has been calculated to be 95%. This is based on a protocol study that's standard for all the vaccinations, that we have. What we are finding is that the safety profile is mild to moderate pain at the injection site, along with systemic reactions of fatigue and headache. And there's an adverse event rate that's similar to other vaccines. However, as we noted when we looked at demographics, and we also mentioned earlier, these reports really don't address certain subgroups. And for example, there is you cannot analyze this for Native Americans. This report does not address children, adolescents, or pregnant women. So those are going to be ongoing. I know that there is, I'm not sure if it's enrollment still or if it's already started, but one focusing on children. And that's why right now we can give the Pfizer vaccine to those 16 years old and older. So it's going to be, to be able to give it to children will be delayed probably till sometime like early summer or something like that, late spring. There is ongoing monitoring and surveillance for adverse events, and that's going to be including all of us to participate in that. And at the end of the day, this is critical for global control of the pandemic. We cannot go with herd immunity. That results in way too many deaths. And or I should say natural herd immunity. But what remains for us as those in tribal health, I think the real challenge will be in communicating and informing our tribal communities that they make informed choices regarding the vaccine in a way that's culturally sensitive, historically and context sensitive ways. And that's one of the things that I've been recently talking to with Sikui and with the area office, is ways to think about moving that forward. How can we help you as those who, we are all jointly in this tribal health effort? How can we provide tools and resources towards that end of effective communication and informing of our tribal communities? That's my last slide.
Thank you. Does anyone have any questions? Make sure you unmute yourself. Everyone put themselves on mute. So if you have a question, please make sure you unmute yourself. Nope, I don't see anybody. Let me see if there's anything in the
Anything on the
chat.
chat? Okay.
Nope, I don't see anything, but it was a very helpful information. I saw the actual report, but trying to understand it can be challenging for someone who is not, in tune to the medical type of terminology. So thanks for breaking it down for us. I appreciate that. And so we have Rachel Harvey from the Indian Health Service, California area office to provide an update as well.
This is Rachel. Can you hear me?
I sure can. Go right ahead.
Thank you. So I'm the California area IHS point of contact for the COVID-19 vaccine. And I apologize, I don't have any slides, but I just have a very brief update on our vaccine distribution activities. So like Vanessa mentioned, we've been allotted 975 doses of the Pfizer ultra cold vaccine, and then 5,000 doses of the Moderna frozen vaccine for phase 1. And the Pfizer vaccine actually arrived at Pitt River Health Service this morning, and redistribution to 7 spoke sites will start as early as tomorrow. So we know all of our spoke sites are busy scheduling their healthcare personnel to receive the vaccine within 5 days of retrieving it from Pitt River. We do have that short time frame once the vaccine is removed from the ultra cold freezer. We also know that both of the vaccines are 2-dose series at 21 and 28 days, and Operation Warp Speed is holding back the second dose to ensure everyone can complete their series. So this means that all the doses delivered this week and hopefully next week are for the first dose of the series, and we'll receive an additional allocation in a few weeks for the second doses. So depending on when the emergency use authorization is approved for the frozen Moderna vaccine, it could ship as early as next week. And the order's already been placed for all California tribal and urban Indian health programs that chose to receive the vaccine through the IHS. So that's based on the data submitted by the programs. All should have more than enough to cover all of their interested healthcare workers. And depending on interest, some sites may be able to move through their priority list. We don't want any wasted vaccine. So I'll be in touch with each program's vaccine point of contact once I receive a shipping date. And we're still working through the data reporting process with all the sites. There was a data reporting office hours yesterday and again today. And tomorrow there will be another VAMS or Vaccine Administration Management System training. And I'm sending out that information as I receive it. So I'll just give a quick plug for our California area IHS Vaccine Task Force office hours. Those occur weekly on Mondays at 11 a.m. So let me know if you need that call information, and I'm happy to answer any questions.
Don't forget to unmute yourself if anyone has any questions, or you can ask your question or your comment in the chat function.
Hey, Rachel, this is Frank from Tuolumne. Can you hear me okay?
Yeah.
Hey, just quick question. So, we have plans on the Moderna vaccine, so we're looking forward to that. But I guess my question is, and we've had questions here, as I'm sure you've been bombarded with questions. We all have. So, do we have a sense when the next Moderna or the next Pfizer or the second phase 2 shipment, or are we going to see how phase 1 deploys first and then discuss phase 2?
So I did ask that question of headquarters, and the only thing they responded with was that we'll for sure get the second dose. They didn't talk about the second allocation. I did hear on another call that we'll be able to make weekly ordering, but that the first order that occurs after this initial one will only be like 20% of that order. So it'll be a lot less. So I don't really have that much more information at this time.
Okay, but my understanding was when the initial allocation of doses we get is so for example, if you're going to get 100 doses, that's for 50 people. Is that correct?
No. So if you get 100 doses next week, that'll be for 100 people, and you'll get the second dose for those 100 patients
Okay.
when it's time.
Okay. So within that 28 day or that 21 to 28 day window.
Yep.
Okay. Okay. Good to know. Thank you.
That's a good clarifying question, because I know people may, I think there's also some people get confused about what's coming in the package, how many vials, how many doses, and then how many people are you expected to utilize that vaccine on, and knowing that, clarification that there's a second dose that's supposed to be coming because it is a 2-dose vaccine. It's kind of quiet.
And I just wanted to clarify.
Go ahead.
I just wanted to clarify again that we don't yet have the Moderna vaccine, but we were able to put in an early order so that as soon as the EUA is signed, it should be shipped out within 24, no more than 72 hours after that.
Okay.
So Rachel, I just have a question. I'm just trying to make sure I understand everything. So if you have 975 doses, that means you actually have doses for 487 people, like half of that? Is that what it means?
No. So the 975 doses of the Pfizer is going to go to 975 patients.
Okay.
And then the second dose will be provided before the 21-day mark when they need the second dose.
Okay, I got it. Thank you.
Any other questions? Doses question, vial question, ice question, storage?
This is Rosario. I had a question with regards to whether everyone was able to get the thermometer, the logs, the continuous log thermometer that they would need to transport. And if the second question was whether people needed to have access to a faster way of transporting medication between sites, as in by air or local charter flights. Everyone's good with what they need then to go pick up the medications and have a plan to get it back, right?
So everyone has to go to Pitt River to pick up their vaccine? Because through the 7 spoke sites, so whoever those 7 spoke sites are, if there is anyone that is in far proximity to Pitt River, and how that is being transported. I guess everyone's good to go then.
Good, and I only asked because someone in our network of folks asked whether we might need flight support because I guess there's like a regional, what do they call them, civil air patrol that can actually airlift and bring, I guess, the vaccine. They're doing that in other regions, and so then they asked whether we might be interested in having that in California, but it sounds like everyone's got it covered, probably via ground, it should be fine. So just wanted to make sure we put that out there.
Thank you. Rachel, can you share who the spoke sites are?
Yes. I'm just opening up my file here. Northern Valley, MACT, Indian Health Center, Santa Clara Valley, Table Mountain, Lassen, Southern Indian Health Council, and Shingle Springs.
So I have Northern Valley Indian Health, MACT Health Board, Indian Health Center of Santa Clara Valley, Table Mountain, Lassen Indian Health Clinic, and Shingle Springs Tribal Health Program. I'm missing one.
And Southern Indian Health Council.
Southern Indian Health Council. Got it. Okay, thank you. I don't see any questions and there's nothing in the chat box. So thank you for spending time with us, Rachel. I appreciate it. You guys are always very responsive in our request to provide an update. So thank you for that.
Thank you.
I don't have anything else on the agenda unless anyone has any questions for the group or for CRIB or for any other clinics. Please feel free to unmute yourself if you have any other comments or questions. Everyone's quiet today. That's okay. I know we're all tired and it's only Tuesday. So with that, everyone enjoy the rest of their afternoon and evening and stay safe, and we'll be talking soon again. Thank you.
Thank you.